So my presentation is called Contrast Enhanced Ultrasound of the Liver and Kidney, Why a Whole Body Indication. These are my disclosures, which are unrelated to this presentation. So when we consider a whole body indication, is there a precedent? Yes, I believe there is a precedent in that CT and MRI obtain enhancement for interpretation of the entire body on every injection. Now, CEUS with a single injection will also show enhancement of all of the abdominal organs and others, and these injections show multiple adjacent organs which may be involved with the same or with unrelated pathology. And we should, of course, be interpreting all. And these injections are additionally safe and require no ionizing radiation. So let's start off by looking at a very, very striking and important issue when it comes to using CEUS. And this is in the patient with renal failure or allergy to contrast agents for CT and MR scan. So this is a very common clinical problem, and it results in the performance of unenhanced CT scan and less frequently unenhanced MRI. So many unenhanced scans are performed every day in the USA. And so the clinical situation goes something like this. Patients are either booked for a routine CT scan, or they come from offices or emergency departments, and the technologists performing the study realize that the patient has renal failure. This can be confirmed with a simple blood test by measuring the serum creatinine. And so in patients with compromised renal function, they are not eligible to have a CT scan. So instead of booking another procedure, these patients instead have a study that's converted from a contrast-enhanced CT scan to an unenhanced scan. And this is a major problem. And I'd like to start by giving you an example of a striking case. So this is a 42-year-old male, 6 weeks post-radical nephrectomy for renal cell carcinoma. He presents to the emergency department in the middle of the night with acute right flank pain. And so the doctor orders a CT scan for this patient. And when the patient is evaluated, it's found that he has an elevated creatinine. So instead of performing a contrast-enhanced scan, they perform an unenhanced CT. So here are 4 images that were taken from that CT scan, and we can see that there's a large low attenuation mass in the retroperitoneum on the right side of the body. We can see within this low attenuation area that there's some high signal intensity material. And when we look in the lower abdomen, we see what looks like a fluid debris level, thought to be like a hematocrit. So this interpretation very reasonably was that of a spontaneous retroperitoneum bleed with hemorrhage formation. So a retroperitoneal hematoma was the patient's admitting diagnosis, and the patient was in the hospital for pain control for several days. So sometime down the week, the patient was sent to ultrasound for a reevaluation of his retroperitoneal hematoma. So one of my lovely sonographers took this long axis and axial view of this patient, and she sees this big mixed echogenic mass in the retroperitoneum. So she brings me these nice pictures and she shows them to me, and I looked at it and I said, "What is that?" And she said, "A retroperitoneal hematoma." And I said, "How did you know that?" And she said, "The CT scan told me." And I thought, oh dear, not so suggestive of a hematoma. So of course, what do? The same thing that we do to solve many of our problems in my department. We perform contrast-enhanced ultrasound. So here we can see a very nice axial image looking at the liver at the front of the picture, lovely homogeneous enhancement, no problem with the liver. But when we look at the mass where the retroperitoneal hematoma is expected, we see instead that all of this is heterogeneously enhancing material. So this retroperitoneal so-called hematoma is not a hematoma at all, and this enhancing mass which measures up to 20 centimeters in diameter, is in fact reflective of infiltrative carcinoma in the retroperitoneum. And so this shows very well that contrast-enhanced ultrasound can solve this very important problem easily, whereas the unenhanced CT scan cannot, in fact, solve this issue. So contrast-enhanced ultrasound in the many patients that have renal failure is far superior to the performance of a non-enhanced CT scan. CT scan relies on its improved ability to show solid organ pathology on the basis of intravenous contrast injection. And so ultrasound, in fact, is superior in terms of resolution as compared to baseline CT scan. And CEUS is far superior to not enhanced CT scan for demonstration and characterization of all solid organ pathology. And the reference which I list at the bottom of that page comes from my own department, where we looked at over 200 patients as they were about to have a non-enhanced CT scan. And we took them to our department, recruited the patients, and performed contrast-enhanced ultrasound with really excellent results for all of the abdominal organs. So having used that as an introductory case, I'd like to now change over to a different approach and look at the value of CEUS. So let's look at why CEUS is valuable as an imaging technique. First of all, there are functional strengths of CEUS. These include a dynamic real-time scanning technique, intravascular contrast agent, a subtraction technique that produces a microbubble-only image, and the use of thin slice thickness, which removes the problem that plagues CT and MR scan called volume averaging. And then at the end of the presentation, I'll briefly touch on two arenas in which CEUS operates. And this, of course, is CEUS LI-RADS, a recently developed, very important technique for masses in at-risk livers, and the Bosniak Classification for looking at cystic renal masses. So let's start off with the first of these, and this is dynamic real-time scanning. So this shows rapid enhancement patterns that characterize most benign liver tumors. So this obviously makes the technique good for this diagnosis. Dynamic real-time scanning shows the subtle changes in vascularity within nodules during hepatocarcinogenesis, or the evolution of HCC. And this is a very special technique, which we really don't have time to talk about today. And in addition, dynamic real-time scanning shows the sensitive depiction of transient hypervascularity before rapid washout, which occurs in all metastatic tumors. So let's look first at the benign liver tumors. So contrast-enhanced ultrasound shows the rapidly changing patterns of enhancement. And so for our three common tumors, there's peripheral nodular enhancement, familiar for hemangioma, centrifugal filling with stellate vasculature in FNH, and centripetal filling with dysmorphic vessels in some patients with adenoma. And so if we believe that CEUS is excellent for diagnosis of benign liver tumors, the next step, of course, which is a natural, is that CEUS will be excellent for the diagnosis of incidentally detected liver tumors. So we all know that when you're having CT, MR, or ultrasound, that many masses are found as an incidental observation. And it's been well published and well studied that most of the lesions that are found incidentally turn out to be benign. So therefore, in your institution and in mine, CEUS is the best and easiest first choice to resolve an incidental liver tumor. So let's look at an incidental tumor. So this is a patient who has surveillance ultrasound, and this patient has HBV cirrhosis. So when we look at this ultrasound image, we can see marked by the arrow a small hypoechoic mass with an echogenic rim. So this mass is above our 1 centimeter threshold for characterization, and so we perform a CEUS scan. So the little tumor marked by the arrow, you can see filled very rapidly from the periphery of the mass into the center with puddles of contrast. And so this suggests that this is a benign hemangioma. And when we look at images at 25 seconds, at 1 minute, and at 4 minutes, we can see that the mass is now uniformly enhanced with sustained enhancement and no washout. So this is a flash-filling hemangioma, and no further investigation is required. So this is a full stop scan for this patient. And so this patient subsequently, because of the HBV status, did have an MR scan. And when we look at this MR scan, we can see the arrow marks a T1 dark nodule in the liver. And when we come to the images taken following the gadolinium injection, we can see that although we show enhancement of the mass, we don't show those peripheral puddles or the centripetal progression of their enhancement. And so the dynamic real-time capability of CEUS is really a valuable aid for diagnosis of these lesions. Now, when we look at the kidney in comparison, the kidney doesn't rely so much on this rapid technique for actual vessel patterns, but let's look at this patient, a 28-year-old female who had an incidentally found renal mass on a CT scan that was performed for abdominal pain. You can see on the sagittal and the coronal view that the arrows marking a small, low attenuation mass in that kidney. And so this scan, done only in the portal venous phase, does not give enough information for diagnosis of that mass. So this young lady was sent for ultrasound, and we can see a very nice picture on the left that shows an echogenic mass exophytic to the kidney. And when we add Doppler, we can see that there's perilesional and intralesional vascularity. Now, the patient was sent from there for characterization further with CEUS. And so when we inject the contrast, you can see on the left image that we're looking first at a conventional arterial phase wash-in, and we confirm that this is a hyper-enhancing and homogeneous mass. Now, when we use a bubble tracking technique, we can see actually that the mass looks almost like an FNH within the kidney. So this is a mass that's filling from the center with stellate vessels and a centrifugal filling pattern. And although this is very uncommonly shown when we're looking at renal images, we thought this would be an oncocytoma, which in fact is a solid tumor of the kidney, but it is benign. So a rare benign neoplasm diagnosed completely on contrast-enhanced ultrasound with the use of dynamic real-time scan. So let's go on to another very important situation, and that's the oncology patient who has a history of malignancy and who has a portal venous phase CT scan. So this is a 52-year-old man with a history of pancreatic cancer, and only days before he had this CT scan, he had a PET scan, and the PET scan was normal. And clinicians, oncologists, all people put tremendous stock in the PET report. And if the PET report is negative, they believe it has to be negative. So the clinician called me and said, Stephanie, can you look at this? And so I looked at the image and I said, well, I can't guess what this low attenuation mass is. Let's send him for a scan. So this patient comes with that low attenuation mass. And of course, we're thinking, is this an insignificant cyst in his liver, or is this an important tumor? So when we look at the grayscale picture, you can see that in fact half of the mass is black, looking cystic, and the arrows marking a thick rim around the edge of that mass. So when we do the contrast exam, you can see that there's an enhancing rim. So that rim of solid tissue is enhancing. It enhances less than the liver, but you can see as the bubbles arrive that there's the black part, and then there's the bubbles coming in to that enhancing rim. So the rim enhances in the arterial phase, and then when we look at the subsequent images, you can see at 30 seconds that it's enhanced, but by 1 minute, the enhancement has gone down. So this shows rapid washout. And of course, this progresses, and at 4 minutes, the whole mass, both the cystic part and the solid rim, are now black. So what is this? It's a complex cystic mass which has arterial phase enhancement with rapid marked washout. So what do we think about? We think about non-hepatocellular malignancy, and in this patient, we suggest a cystic pancreatic metastasis, and this is confirmed. And so this is a very, very strong case that supports a belief we have that ultrasound with contrast is invaluable for resolution of indeterminate low attenuation masses on CT scan in oncology patients. So in terms of our looking at real-time scanning, we've looked at 3 very different clinical examples, and real-time scanning is important in all of those situations, but really it's important everywhere. So we use it on every case performed every day on every organ, and this is true everywhere that people are doing contrast ultrasound, and great advantage from this wonderful aspect of this technique. So the next thing we should consider that's very important also is that the microbubble contrast agents which we use are purely intravascular contrast agents. So the microbubbles go nowhere except within the vessels. So contrast-enhanced ultrasound shows sensitive depiction of washout in all malignant tumors. And so CT and MRI with an interstitial contrast agent may show instead sustained or increasing pseudo-enhancement. So while the contrast stays in the vessels on CEUS, CT and MR contrast have a phase where they pass through vascular endothelium, especially in malignant tumors, and go into the interstitium. So recognition of discordance between MRI and CEUS in their a recognition of washout increases suspicion for a certain tumor, and this is cholangiocarcinoma. Let's look at a 41-year-old male with alcohol liver disease and a focal liver mass on MRI. So you can see here on the T1 weighted image that we're looking at a hypo mass, a dark mass on T1. When we inject the contrast agent, we can see in the arterial phase that the mass has a rim of hyperenhancement and hyperenhancement heterogeneously inside. And in the portal venous phase, we can see that that rim of enhancement and the enhancement within the mass is either increased or sustained. And so what are we thinking of here? We don't know what this is, so this is an indeterminate result on MRI. And so when the patient is referred for CEUS, we can see this echogenic mass in the liver. And when we inject the contrast agent, we can see that, in fact, this mass enhances very avidly in the arterial phase. So before the liver is enhanced, the mass is totally hyper-enhancing. Now we're going to run this clip continuously for several seconds. And now you can see that before your eyes that mass has started to wash out. And so the mass is now dark as the liver. And before the clip ends here, you'll see that the mass will have become darker than the liver. So this is a patient who shows transient hypervascularity and then rapid washout. And so when we look at these images together, we can see the arterial phase images on the left-hand side both show arterial phase enhancement. But when we look in the portal venous late phase, you can see that the CEUS image on the bottom shows rapid marked washout, whereas the mass in the portal venous late phase on the MR scan continues to show the enhancement. And so this is not real enhancement, this is in fact pseudo-enhancement. And so when we realize that we see this type of discordance, we're instantly suspicious of cholangiocarcinoma, and this is a biopsy-proven cholangiocarcinoma, and we recommend interpretation of CEUS with MR in these circumstances. So I'd like to bring your attention to 2 old publications from over 10 years ago. And these are both arising from the Spanish literature. And these are papers that are actually attacking the use of contrast-enhanced ultrasound for the diagnosis of cholangiocarcinoma and hepatocellular carcinoma. And their belief was, and what they've written, is that because CEUS did not show the same delayed enhancement and sustained enhancement as MR, that it was not showing the actual enhancement feature. And of course, even prior to this, we were aware that that was pseudo-enhancement, and this has now been well refuted in the ultrasound literature. And so today there are some very good publications talking about the significance of the discordance between the imaging techniques, the recognition of the pseudo-enhancement on MR, and the value of CEUS for diagnosis of both HCC and cholangiocarcinoma. And in this publication, the temporal enhancement analysis performed improves the differentiation of ICC from HCC in cirrhotic patients, and this supports completely what we believe in these cases. So when we're looking at these patients, why do we have this portal venous phase discordance? It's related to microbubble intravascular contrast on CEUS and interstitial contrast going into the tumor interstitium on CT and MR. So this gives us better characterization of masses in that washout of malignancy is invariably present on CEUS, and CEUS is more reliable in assessing vascular volume and flow. So let's look at another similar patient. This is a 74-year-old male, also with cirrhosis, and he has a focal liver mass that was incidentally detected on a prior ultrasound scan. So he comes first for an MR scan, and on his T1 image, we see another dark mass in the back of the liver, and we can see the grayscale correlate, a big mass on the ultrasound scan. So when we look at the ultrasound, we can see that this big mass has got rim hyperenhancement and a big ball of hyperenhancement centrally within this mass. So again, we're letting this clip run a few seconds longer than we often do, and we can see that before our eyes, again, the mass will go from hyperenhanced to less enhanced than the liver. So we show washout within the time frame of a short clip performed all before 1 minute. So if we look at the arterial phase on the ultrasound and on the MR scan, we can show that they're quite similar in some ways in the arterial phase. And then as we progress, we can see that the MR scan continues to show that enhancement centrally, whereas we show that very definite washout of this scan. So what do we think of this case? Well, we show arterial phase hyperenhancement with a rim pattern and rapid marked washout and discordance between CEUS and MRI in the portal venous phase. So what are we thinking? We're again thinking non-hepatocellular malignancy. And of course, I'm really thinking of cholangiocarcinoma. But I include this case to show that not every single case is a cholangiocarcinoma. And here, biopsy shows a non-hepatocellular cancer for sure, but it's B-cell lymphoma. And so we found now in the analysis of many, many cases with this discordance in my own institution that B-cell lymphoma is the next likely thing that you'll see with that discordant pattern. So now let's go to another features of ultrasound. So this includes that the software for ultrasound imaging with CEUS is a subtraction technique which removes all of the baseline imaging. Also, it uses a thin slice thickness, which removes the problem of volume averaging, which can plague both CT and MR scan. And so let's talk first about the subtraction technique. So when we subtract out all of the background linear echogenic parts of our image, we are left with a microbubble only image. So this yields a highly sensitive technique to show enhancement within thin septa and tiny nodules. And although this is very important in liver imaging, it's proved to be particularly significant in looking at kidney masses. Regardless, it's sensitive to both the presence of arterial phase hyperenhancement and washout of contrast. And really, this is invaluable in the characterization work that we've done in all organs in the last decade. So our personal conclusion is that CEUS shows washout, especially with more sensitivity than CT and MRI scan. Now, what about this thin slice thickness? Well, this produces a removal of the problem of volume averaging. And so when we consider the kidney shows a range of masses from solid to simple cystic, with all varieties of complexity in between. And their differentiation on CT and MR scan are compromised by volume averaging, leading to many indeterminate lesions. And CEUS with universal thin slice thickness resolves enhancement in many small nodules and thin septa. So let's look at this beautiful scan. So here's a patient who obviously has a very low attenuation mass on this contrast-enhanced CT scan. Now, when we look at both of the images, you might have a suspicion that there is some enhancing septation within, but it's not really very clear. So compare that with the very definite dramatic appearance on CEUS. So the grayscale images on the left show that there is a high degree of complexity of the cystic mass. So there's thin, but there's also thick septations. And when we come to the contrast injected mass on the right-hand side of the image, you can see very easily, unequivocally, that those central portions of that mass are enhancing. And so this is a cystic renal cell carcinoma, very confidently suggested and confirmed. So indeterminate contrast enhanced CT. So CEUS shows cystic renal cell carcinoma with enhancing septa. And the CT and MRI scan, due to volume averaging, have more difficulty showing enhancement within the septations of renal cell carcinoma. So CEUS easily shows enhancement in cystic RCC, and furthermore, it contributes to all of the other renal diagnoses. So let's look at another low attenuation mass on contrast enhanced CT. So we can see on the arterial and nephrographic phase that the kidney is enhanced, but the mass looks to be almost the same on those images as on the unenhanced image on the left. Now, is this enhancing or is it not? Well, we know that if we have greater than 20 Hounsfield units of increase in the Hounsfield units between the baseline and the nephrographic phase, that it's likely a vascularized mass. So here, this was reported as indeterminate in spite of the fact that it goes from 8 Hounsfield units to 17 in the arterial phase, and then 34 Hounsfield units in the nephrographic phase. And so this, of course, suggests that it could be vascularized, but the people reading it felt it looked so unvascularized that they called it indeterminate. And the patient went on to have MR scan. So here you can see a T1 fat sat image on the top, and then the post-gadolinium images on the bottom. And you can see that there's really no change in the relationship of the enhancement of the renal mass as compared to the kidney, which is enhancing. And when we look at subtraction techniques from the same sequence, we again do not show enhancement of that mass. So it was reported as not conclusive for an enhancing mass. So the patient, when he has contrast ultrasound, we can see on the grayscale an obviously exophytic solid mass. And when we inject the contrast agent, we see unequivocally that this is an enhancing mass. So the kidney is enhancing more, but you can see when the bubbles arrive, you can see the bubbles coming into this mass. And this low enhancing solid mass is a solid vascular mass, and this represents a papillary renal cell carcinoma. Now, this carcinoma has created a lot of problem in that this is a solid mass on ultrasound and an enhancing mass on CEUS. And the enhancement relative to the kidney is low, and it creates a potential for misdiagnosis as a cyst or a complicated cyst on CT and MR scan, as here. And so Dr. Vikram wrote a very nice article about this, and you can see his lovely pictures on CT scan showing the typical low attenuation and the low vascularity that's present in papillary carcinoma. And so certainly papillary carcinoma is another strength for CEUS. So if we consider the kidney and the liver as two areas that have received a lot of attention since the approval of microbubbles in North America. After the liver, there's no question that the kidney is the most established for CEUS characterization. And two pathologies in particular demonstrate the superior sensitivity of CEUS to its tracer. And these are, of course, cystic renal cell carcinoma and papillary carcinoma. So where do we go from here? So now I'd like to discuss two political arenas for CEUS of the liver and the kidney, and namely CEUS LI-RADS and the Bosniak Classification of renal masses. So LI-RADS stands for the Liver Imaging Reporting and Data System, and it does many things, but it provides an ordinal risk classification system for observations on liver imaging in patients at high risk for developing HCC. So if we consider that the vast majority of malignant tumors that arise in the cirrhotic liver are of hepatocellular origin, and they can be classified with LI-RADS according to a probabilistic scale from LR1 with no consideration for malignancy up to LR5, where we want high confidence for the diagnosis of HCC. And non-HCC malignancies, which fall largely into an LRM category, they deviate from this ordinal approach and may best be considered lateral to LR5 in terms of the probability of malignancy. So here we have the version 2017 CEUS LI-RADS core algorithm, and this is taken from the ACR website. And so at the top, you can see the categories LR1 to 5, that's between the green and the red bars. And then at the bottom, we have a diagnostic table, which looks after the nodules of hepatogenic origin. And so these are both very important to us. But if we consider all of the categories on the LI-RADS slide, there are two that are most important. So the first is LR5. So that's the extreme of diagnosis. So there are three criteria for diagnosis of HCC. And this is a tumor of greater than 1 centimeter size. In the arterial phase, it shows arterial phase hyperenhancement, and then it shows late and weak washout. And if you have all of those three criteria, this is a very stringent restriction, then you can call it LR5, and it should be HCC. Now, in addition to LR5, the next most important category is LRM. And so this is a tumor that's got definite or probable malignant potential, and it does not have the specificity for HCC. So either of these features can put any tumor into LRM, and that includes arterial phase hyperenhancement, that is rim pattern, and rapid marked washout. And so let's look a little bit more at this. So LR5 within LI-RADS, so a major objective of LI-RADS is high specificity for the diagnosis of HCC in LR5. So the CEUS LI-RADS category requires all of the criteria that we just discussed. And so validation studies performed in Italy and in Canada confirm the high specificity of the LR5 category, and they permit treatment of HCC without invasive biopsy. So this has had a tremendous impact on looking at the chronic liver population everywhere in the world that uses this technique. And so the data supports utilization of CEUS in diagnosing HCC in cirrhotic patients. So this LI-RADS category serves as a reference standard in that it negates the need for pathologic proof. So the algorithm is designed to emphasize the positive predictive value and specificity over sensitivity for diagnosis of HCC. And the goal is 100% specificity. And that means that we don't want any false positives for the diagnosis of HCC. And we don't mind if not all of the HCC come into this category, in that it's perfectly fine for them to go elsewhere to lower categories or to LRM. We just don't want anything else inside LR5. So here's a classic LI-RADS 5, a small hypoechoic tumor on the top left corner. On the bottom, on the left, we see arterial phase hyperenhancement. At 1 minute, right in the middle of the slide, you can see isovascularity. And then at 2 minutes, we start to see late and weak washout, which becomes more washed out by 4 minutes. A classic LI-RADS 5, the patient may be treated without biopsy. Now let's talk briefly about LRM. So unlike other diagnostic algorithms for HCC, LI-RADS provides a category for lesions that are definitely or probably malignant, but not specific for HCC. And so what this does is it preserves the specificity of HCC diagnosis while maintaining a reasonably high sensitivity for detection of malignancy and appropriately directing care in patients with malignant disease. And so in our own validation study, all of the malignant tumors that we had virtually were within LRM and LR5. And so here's an example of a classic LRM. So first of all, we can see that there's 2 masses in the liver, which always raises our concern for metastatic disease. On the bottom left picture in the arterial phase, we show rim hyperenhancement. And then at the 1 minute and 2 minute images, we show washout and disappearance of the rim. So rapid washout, rim enhancement, this is LRM, proven metastatic disease in a cirrhotic liver. So HCC and ICC within LI-RADS, LR5 allows us confident diagnosis of HCC where we can treat and transplant without biopsy. LRM should detect virtually all other malignancies, both ICC and metastases. And of course, we have to remember that about 1/3 of LRM in our own study turned out to be HCC. So we're going to find these though because we do biopsy on all patients within the LRM category. Now, what about kidney masses? Well, incidental detection of renal masses is commonplace, and the Bosniak classification from 1 for simple cysts to 4, where there's more solid tumors, solves many lesions, but leaves many others unresolved and requiring biopsy. And so on contrast enhanced ultrasound, we know that all solid vascular tumors are malignant. And this includes tumors that have malignant components that are solid and vascular, and that all simple cysts that are avascular will be benign. So malignant cystic tumors show enhancement of the thickened wall septations and internal components of the mass. So let's look at another renal mass. Here's a patient with a high attenuation mass on the scan in the arterial phase and the nephrographic phase. The kidney enhances and the mass remains low attenuation. So this is an indeterminate mass prior to CEUS. So the patient comes for CEUS. We can see a mass that's cystic with septations on the grayscale image on the left. And then on our clip, you can see without question gross enhancement of the internal septations. And this allows us to extract these very nice images. And so CEUS makes a consistent contribution to the diagnosis of cystic renal cell carcinoma, as CT and MRI will often fail to show enhancement within septations of a cystic mass. So the Bosniak classification, so there are a large number of complicated cystic lesions that range from clearly benign to clearly malignant. And these lesions are classified using the classification developed first for CT and then modified to include MRI. And so the Bosniak classification currently does not include CEUS, but Bosniak categories 2 and 3 have many indeterminate results leading to biopsies of both malignant but also many benign tumors. And so kidney CEUS has exceptional sensitivity and specificity in characterizing indeterminate renal masses. CEUS has a high positive predictive value and a negative predictive value in characterizing indeterminate renal masses as benign or malignant. And this work, of course, is done by our next speaker, Richard Barr, and it's really the best and most comprehensive work that's been done on kidney CEUS. So CEUS makes valuable contributions to accurate diagnosis of cystic lesions in the kidney. So today we've looked at contrast-enhanced ultrasound of the kidney and the liver. We've looked at dynamic real-time scanning with CEUS to provide incomparable high-resolution imaging of the kidney and the liver. And we feel that CEUS resolves ambiguous results on CT and MRI scan, improving patient outcomes and reducing downstream testing. And I think this is one of the major benefits of CEUS, to resolve things that are not clear from CT and MR. And CEUS is comparable to MR in showing arterial phase enhancement, but we believe that CEUS is superior to MRI in showing washout as a sign of malignancy. And so this low-cost modality, free of ionizing radiation and without nephrotoxicity, is an essential addition to all abdominal imaging departments. Thanks for your attention, and I'd like to welcome my colleague, Richard Barr.